Good day, colleagues. My name is Sibeko, Head of Addiction Psychiatry at University of Cape Town, Director of ITTC South Africa, and Scientific Global Advisor for ISAP Global. I apologize for not being able to join you in person today. Unfortunately, my sinusitis got really bad and I wasn't able to travel. So I'm sorry to be missing this year's Lisbon Addictions Conference. The ITTC South Africa is located within the Division of Addiction Psychiatry at the University of Cape Town. What you see in this slide is our campus. So you see right at the bottom there, I'm sure many of you have visited us. Please come back and see us again. And we're at the Faculty of Health Sciences on Anzio Road. The ITTC has three main activities. I won't go into too much detail about all of them for the sake of time. But broadly, it's to support the development and implementation of national and regional drug and alcohol policies. And secondly, to expand the uptake of evidence-based best practice. And finally, to assess and remove barriers for evidence-based or for the adoption of evidence-based best practice for substance use prevention, treatment, recovery services in South Africa. Some of the examples I'll share today really focus on this particular aim. ITTC South Africa does not exist in a vacuum. We're part of a global drug demand reduction collaborative. We work closely with partners such as ISAP, ICDDR, African Union Commission, and others, as you can see on this slide. So in addressing the topic of my talk today, being engaging governments and providing capacity building and technical assistance, I'm going to start by providing the Department of Correctional Services example, talk about how that has led to the development of the web app version of the WHO Assist, and then highlight other government collaborations, and then sort of look broadly at what some of the enablers and some of the takeaways have been from this collaborative work. Apologies for all the sirens in the previous slide. At least that way you know it's not AI, that I'm really making this recording. So what did we aim to do in collaboration with Department of Correctional Services? Department of Corrections has been a long-standing partner of the ITTC and of the Department of Psychiatry and Mental Health through the Division of Addiction Psychiatry. So they came to us and said, listen, we want to characterize the extent and nature of substance of abuse within the prison population amongst inmates. We want to provide capacity for staff at correctional services to not only train providers within Department of Corrections, but also to be able to provide screening, brief intervention, and referral to treatment. They wanted to capacitate the providers at Department of Corrections to function as an important resource for SBIRT, which we know is an evidence-based intervention for early intervention for substance use. And to then provide findings that will assist DCS in reviewing their policy and strategy, and to facilitate the integration of SBIRT for DCS as part of their intended broader public health approach, extending really into service reintegration. So we chose the assist as the intervention. I'll explain why in a moment. So the activities we undertook was, first, we trained the core management group in SBIRT with a focus on the assist and focusing as well on core motivational interviewing skills as a core component of brief intervention. We then capacitated this core management group to cascade this training to providers, and the providers within corrections include wardens and social and health practitioners. We then provided Department of Corrections with paper versions of the WHO Assist to initiate the initial pilot. So what then took place at each of the correctional facilities is the pilot assist screening was rolled out. What we then did is we collected that pilot data, captured it, analyzed it, and presented it to the core management group and the management committee for Department of Corrections. Some of the logistical challenges we picked up was that some of the sites were so rural and so far-flung that occasionally there would be challenges getting paper screens to the central location where they would then be shipped to Cape Town. Some of the deliveries would be mislaid or lost. There might be instances where there were errors in calculation of totals, or it was ineligible, and so when we were trying to then data capture, a lot of data cleaning was required. So these logistical challenges are what drove us to then develop the automated web app version of the Assist, which was then finalized for Department of Corrections rollout by the end of December 2022. As you know, if there's no photos, it means it never happened. So these photos just capture some of that journey. So the initial training meeting that took place in February 2022, amazing how time flies, following the initial engagement in January 22, and followed by the rollout planning meeting, which then took place in Cape Town, incorporating additional training to really reinforce motivational interviewing principles. So this is evidence we actually did the work. So as I mentioned, there were some logistical challenges, and some of these led to some data transfer challenges, which were logistics related. And so some of the demographic data doesn't currently fully match, so we're not going to speak too much about that. But the initial data analysis nevertheless did provide some initial insights. There is a more in-depth exploration of this data, which we're hoping to publish in the near future. So the data collection following the rollout was capped on the 15th of March. Data was captured on the 6th of June. Analysis at the end of June 2022. We had 87 variables, and we were able to access 218 observations, which were then stratified by elicited risk. What was interesting in terms of the finding is that the pattern of risk matched the expected patterns per the Sekendo and SASH data. I'll speak about Sekendo and SASH in a slide briefly in a couple of moments. We found low levels of alcohol risk in keeping with the restrictions imposed by correctional services, and then we were able to then provide comprehensive risk data for this particular sample, which we hope will ensure the ability to plan services responsibly. So I'm going to talk briefly about why it is that we chose the assist. So remember, Department of Corrections came to us and told us they wanted to characterize the nature and extent of substance use within corrections, but additionally wanted to stratify the risks so that they could then responsibly design interventions to provide care for those inmates. And so the assist was essentially a technical assistance plus capacity building intervention that we chose, and this is why we chose it. The assist is not new to anyone in this room, and it is part of the recommended package by World Health Organization. As we know, the assist asks about recent substance use over the past 3 months, and at the same time also assesses lifetime use risks, which is really helpful in understanding and in characterizing a service user and then subsequently a population. There's a comprehensive list of substances, which is long and also includes tobacco, which is often not screened for during expert interventions, and alcohol, which is a key concern in low and middle income countries, not just globally and especially in South Africa. Assist then provides a level of risk for each substance, and then the second part of the tool, which is really helpful for supporting task shifting, task sharing initiatives, is the guidance for the brief intervention component. In this section, there's a provision of information and feedback about the risks and harms associated with each substance, covering physical, medical, and psychological and psychosocial risks of regular substance use. Some of the feedback we've had from policymakers and care providers is, what are you going to do with all of these folks that you pick up who might then need specialized care in circumstances where that's not available? The comfort we can give them is that really only 1 in 20 people who are ever screened using this tool actually require referral for more specialized assessment. The average person will require either just a brief intervention or some psychoeducation. So that's at least you're giving some sort of intervention with the tool, and the actual number of folks who might require those specialized services is actually quite a small sample. Once the assist was tried within Department of Corrections, the question was, well, where else could this be of use? Where can we take this sort of intervention? Which other sectors? Why this came to mind, and which I think will match many other areas around the globe, is that the challenges we needed to address in South Africa is that there's not currently a comprehensive epidemiological data source for mental health and substance use. There's no comprehensive passive risk map for substance use in South Africa. And as we know, there's limited funding and human resource to immediately address these needs. The current strategies include limited indicators, so practitioners will check that a screening has been done, but you don't know much more beyond that. Sekendo is run by the South African Medical Research Council and collects treatment demand data. If anybody needs any more information about Sekendo, I'm happy to provide that. But Sekendo tells us what the treatment demand is, but what we don't know is what is the risk map for folks who haven't reached the level where they need to get into the treatment system. The SASH study was the last nationally representative epidemiological study done in South Africa for mental health and substance use. And this was in 2009, so it's really outdated. We need newer, more current data. We need a living data source to really map the risks of substance use in South Africa. So to introduce the Web App Assist, there's the QR code, there's the URL. It's an anonymized tool, so no personal identifying data is collected. A random code is generated with each screening, which can be recorded in the patient's file for later download should it be required. Any device can be used, it's data light and automated. In fact, not only reduces training burden, but removes it altogether, because this can be self-administered and administered by folks with no specialized training. Screening report and intervention recommendation can then be screenshot or emailed, following which the email entered for receipt is not stored on the system. So we're not able to link. Should somebody screen for themselves and then send themselves their report, we're not going to know where they've sent that to. This is again the QR code for the Web App Assist, and you'll see there's 2 additional QR codes for practitioners in self-screen. I'm going to explain that in a moment. We've designed the web app version of the Assist to capacitate members of the public, so you and I, to go in and self-screen. So we don't need any training to do this. You go in there, access via the QR code, screen for yourself. And the benefit here is the ability to self-administer and really facilitating self-efficacy and ownership. Importantly, we also allow a portal for practitioners to register on the profile and then log on and conduct screens. And those screens can then be saved within their profile. What's helpful in this context is the transferability of screening data. So if Dr. Smith screens patient Y in Cape Town and patient Y is seen by Dr. Ndlovu in the Eastern Cape 4 months later, and they repeat the Web App Assist screening, we can be sure that at least the process of analyzing that information is consistent. There are also special projects that we've done, including the one with Department of Corrections, master's students and others, which are added as required with specific characteristics. In terms of general linkage strategies, for self-screen, there can be QR codes at public health engagements, social media campaigns. Our Department of Social Development has used the QR codes at public engagements, can be at healthcare waiting areas, or strategically placed through screening devices across public health facilities. In terms of practitioners, there can be a QR code again at public health facilities. QR codes can be linked within training materials or care SOPs. QR code can be in healthcare provision areas, or can be strategically placed as devices in public health facilities so that folks can be screened before they are seen by the practitioner. This slide simply shows executive buy-in, where the tool was launched officially by the National Minister of Social Development, alongside the University of Cape Town Vice Chancellor and the Dean of the Faculty of Health Sciences. And the recording for that can be found in the QR code with the red YouTube sign in the middle. Some additional photographs from the executive launch, which demonstrate some of the briefing engagements, as well as involvement of student leadership at University of Cape Town. What's important to note about this slide is that with all the processes that we followed up until now, the key next steps are to then link the data that is received by the Web App Assist that allows us to have that passive risk map with the broader country plan for data integration, incorporating all of the partners that are indicated in the slide at the bottom on the right. There are several other activities that ITT South Africa has similarly been engaged in. With National Department, we've done an expert national policy framework. We've developed the National Foundation Phase curriculum for non-specialist workers. Of course, we're busy now with the Assist integration via the National Data Strategy. We've worked with Department of Corrections in other projects as well, and ATI is an upcoming project that we'll be collaborating closely with them. With the KwaZulu-Natal, which is a province in South Africa, Department of Health, We've worked on cascade model expert and mental health capacity building. We've conducted research, worked on community detection system strengthening within KZN in collaboration with the local university. With Department of Social Development, Central Drug Authority, we've worked on the Addiction Conference, and we've collaborated on the UTC Master Trainers, and we've done some community level engagement in collaboration with the Department of Global Surgery. There are other activities as well with our Department of International Relations, which include participation in the development of the country position for the CND. So this slide summarizes the activities that we've undertaken as ITC South Africa, and from technical assistance to capacity building to network development to policy development in collaboration with our government partners. Why have we succeeded? Because we are genuine collaborators where co-creation is an actual active effort from the start. We design bespoke, responsive, co-constructed solutions. We're accountable in our relationships. We take accountability for our commitments. And we have genuine relationship with our stakeholders. I asked myself as I was preparing this slide, is buy-in a limiting concept? Because buy-in infers that you design an intervention and then you approach the policymakers. Maybe the idea should be that you are working with them from the beginning and that the relationship is an accountable and responsive relationship where buy-in then becomes a moot concept. Thank you so much for your time. I hope you enjoy the rest of the conference, and I'm really once again sorry that I couldn't make it. All the best.